Okay, so this is part B, discussion of substance abuse. So we just finished up discussing addiction. We talked a little bit about the addiction pathway, what addiction is, why addiction is a serious problem. Then we discussed the epidemiology of alcohol and substance abuse, and we kind of put a major emphasis on helping you understand the risks of early alcohol abuse turning into later life addiction, especially among healthcare professionals. So let's just jump in and talk about fetal alcohol syndrome, okay, also known as fetal alcohol spectrum disorder, either FAS or FASD. It's a serious problem that relates from the consumption of alcohol while a female is pregnant, resulting in fetal alcohol syndrome or fetal alcohol spectrum disorder in the child. Okay. So it's a leading known cause of mental retardation in all populations. Okay, remember when we discussed intelligence quotient, we talked about different scales for IQ, in particular the Stanford Bay scale. Okay, so this is one of the first problems that we have with FAS. Okay, is that it does result in mental retardation. Down syndrome or trisomy 21 is the second leading cause of mental retardation in the population. The highest risk is found among people of lower socioeconomic status, so it's very similar to alcohol and other substance abuse here. In the United States, we particularly see it among African Americans, Native Americans, and Latinos. The Native Americans actually have the highest risk factors. So these are the people that were native to the United States before the discovery by Columbus. And one of the biggest problems that we see in terms of the Native Americans is those who are living on the reservations or those areas that are set apart for these individuals, where there are very few opportunities for job, education, political involvement of women. There are also very high rates of teenage pregnancy in those areas. One of the reasons for that is there simply just is not a whole lot for these individuals to do out there. There's also not a whole lot of education provided in terms of public health efforts on the Native American reservations in terms of providing women with information on the risks of fetal alcohol syndrome. Okay, this is probably a good point to mention that FAS is 100% preventable. Okay, this is not something that's only partially preventable. And the way that it's preventable is simply the woman should not drink during pregnancy. Okay, so the minute a female finds out that she's pregnant, she should cease consuming alcohol, because it's the alcohol that actually leads to the fetal alcohol syndrome among the children. Okay, so what do we get with FAS? Characterized by developmental delays. So in other words, these are not going to meet the developmental milestones that we talked about early in the semester. Remember that big chart? Okay, they're going to be significantly delayed in terms of that. We already mentioned they're going to be developmental, or they're going to be mentally retarded, and they're going to have craniofacial abnormalities. They're going to look different. They're going to look somewhat like someone who does have Down syndrome. I'll show you some pictures to illustrate that in just a minute. And also limb dislocations. In other words, they're going to have difficulty. Their limbs are going to become dislocated easily. So in other words, picking a child up by the arms, tossing a child in the air and catching them has the potential to dislocate their arms easily in an FAS child. Okay, shouldn't be tossing a child in the air anyway. That's a great way to engage in Jake and baby syndrome. Remember our discussion about coup and contra coup injuries and the pinpoint angiomas. Okay. So with our public health efforts, okay, and you can be part of these public health efforts in terms of educating young women who are pregnancy age. That should include adolescents in your practice, not just here in Fiji. That's a worldwide problem. But you can focus on the risk. Okay, we generally tend to tell our patients that even a small amount of alcohol is a risk. Okay, why do we do that? Well, scientifically, we're pretty sure that it's going to require large amounts of alcohol consumption over a period of time during the pregnancy to result in FAS, but we don't know where the line is. We don't know, X number of drinks per day is safe, but Y number of drinks per day is not safe. We don't know where that line is because everyone is different. Everyone has a genetic predisposition to their ability to handle and process alcohol through the liver. Metabolism plays a role. People with faster metabolism can break down the alcohol quicker, and so they're less likely to develop alcohol substance abuse problems, and in females less likely to develop alcohol syndrome in their unborn child. And then there's also just the plain issue of size. Individuals who are larger tend to be able to process alcohol at a better rate than individuals that are smaller. So there's too much variance between individuals, and so we simply educate our patients, look, the minute you know you're pregnant, don't drink alcohol. And that should go for you as well. All right, for the females that are listening today that are planning on having a family one day, just don't drink alcohol when you're pregnant. That's the safest way, okay? And that is why I stress that FAS is 100%. All right, I mentioned the craniofacial abnormalities just a minute ago, and here's a couple of examples of that. Look at the area between the nose. I don't know if you can see the cursor or not here, but if you look at the bridge of the nose in all of these children, it's very wide, okay? We call that the flat nasal bridge, okay? That's a significant factor there we see in terms of their appearance, okay? The other thing that we're going to see is that I want you to remember, so the flat nasal bridge is what I want you to remember, and then look at the upper lip. Look how thin it is, all right? The child has a very thin upper lip, and the way I know this, it looks like the child can benefit from a little Botox there, and not Botox, but a little collagen therapy in the lips there to form those out. But the point is, you get that flat bridge across the nose, okay? In other words, you get a widespread area between the two eyes, the flat nose bridge there, and then you're going to get that thin upper lip. The other thing is, notice we have what we call the smooth philtrum, okay? If you feel your own upper lip, okay, between the center of the nose down to the lip, you'll feel that there's a crevice, there's a divot there, okay? Child with FAS isn't going to have that, okay? And it's all a result of the alcohol having an impact on the physical or the craniofacial development of the child in utero. All right, let's talk a little bit about genetics here. I mentioned this throughout the semester. One thing I remember specifically mentioning in some of the earlier lectures that I want to remind you about now is that when it comes to disease rates, a lot of times what we say is it's going to be genetics plus environment is going to equal the pathology. So in other words, there's almost always some type of genetic factor that is going to be at play, coupled with environmental factors to give us a disease. So if we look at alcohol as a wonderful example here, we hear a lot now about this idea of an alcohol gene, okay? That some people are going to have an alcohol gene and it's going to make them alcoholic. Well, basically the alcohol gene that we've discovered doesn't automatically make you an alcoholic. What it is it's a gene that is going to temper your ability to effectively process the alcohol through the liver. In other words, get it out of your body quicker. So those with the alcohol gene tend to retain the alcohol a little bit longer in their systems, hence they develop a dependence upon the alcohol a little bit easier, okay? So, but if you think about this idea of genes plus environment, let's assume that I have the alcohol gene, okay? Now, that would be the genetic role. What about the environmental factor? Well, the environmental factor is I don't drink alcohol, okay? So I have genes, but I don't have environment, hence I won't have the pathology, okay? You can say the same thing for heart disease, because we know there's an increasing genetic association between heart disease and family background. So if I have the heart disease gene, okay, but I exercise right, or I eat right, I watch my cholesterol, I keep my blood pressure down, okay, I'm not going to have the environmental factor there, and so I'm not going to result in the cardiovascular disease. So keep in mind, it's this genes plus environment that's going to equal the pathology, and it's the same thing with the alcohol, okay? Who do we see the alcohol gene in? We tend to see people of Northern European descent, so that would be my particular ethnic group, people coming from the Scandinavian countries, England, even Germany, the Benelux countries, so that would be like Belgium, Luxembourg, and Holland, okay? These tend to be the individuals who have a greater genetic predisposition to alcohol abuse. Groups that, if we're looking at traditional groups from the other side of the world that have lower abuse, include people of Asian, Jewish, and Italian descent, all right? Here in the Pacific, we do seem to see that native Pacific Islanders tend to have higher rates of alcohol abuse and tend to have higher rates of the presence of the alcohol gene than those of other particular ethnic groups, okay? And that seems to be Pacific-wide. All right, so if you just look at some factors here that illustrate this genes plus environment, if the biological father is an alcoholic, the incidence of alcoholism among males adopted into a non-alcoholic family, okay, is equal to that of a son raised by the biological father, okay? So we were talking about the biopsychosocial model here, okay? The bio would be the genetics, okay? And then we would have the psychosocial elements. Here, this illustrates the fact that the social element plays a huge role here. So if we take a dad that's an alcoholic, okay? And he adopts a male son into the family. Okay, the male son obviously isn't necessarily going to share the alcohol gene that the father has because it's not a biological relationship. All right, but the social environment plays such a huge role. The child sees dad drinking alcohol. Maybe dad exposes the male child to alcohol at an early age, and so what do we get? Okay, we get that. We get alcoholism rates that are equal to if the son had actually been a biological offspring of the father. So remember, it's a biopsychosocial model. Biology plays a role, psychology plays a role, and so does the social environment. And here we have a strong illustration of the importance of social environment. Same thing again, what role does prevention play in a situation like this? It's that same idea that we need to educate families not only of the genetic predisposition, and I suggest that the days are coming where we'll be able to do genetic testing at the off-base level, and we'll be able to give people individualized counseling, in terms of avoiding alcohol or in terms of avoiding diets high in fats and sugars and things like that, okay? That's sometime in the future. Right now, what we need to do is we need to counsel people. Everyone needs to assume that they are at risk for alcoholism if they consume enough alcohol, and that the social environment of the home can play a huge role in terms of impacting those rates. Okay, a family history of alcoholism is linked to an increase in major depression in children. All right, so I mentioned in one of the previous lectures that there seems to be association between depression and alcoholism, and here we see how that plays out not only just in the individual who's the alcoholic, but that plays out in the home environment. Think about the home environment where there's an alcoholic. Alcoholism increases the rates of physical violence among children and spouses, sexual violence, psychological violence, rates of job loss, socioeconomic disenfranchisement, and so it's not surprising that the child who comes from a home where they see alcoholism, maybe they see dad abusing mom, and they know that they can't protect the mother because they're weaker than dad, all right? It's not surprising that this results in major depressive episodes among these kids. Unipolar depression is simply the term that we apply to major depressive episodes, okay? So like I said, the key is that the gene-alcohol interaction is the ability to tolerate the alcohol and break it down in the liver. Like I mentioned at the beginning, that's what the alcohol gene does or doesn't do for individuals, okay? And there we have it again, genes plus the environmental exposure disease state. Let's jump ahead. How do we screen these individuals? All right, so if you're a dentist, okay, and you're not a psychiatrist, you're not even a general practitioner, you're there to take care of the teeth, but once again, it's still important that you be able to screen these individuals and recognize it, and so we need a rather quick method for you, all right? Nothing too in-depth that would require you to, have a background in psychiatry or anything like that, okay? So screening does play an important role. So we have one tool we call CAGE. All right, it's an acronym here. All right, so let's just go through each individual letter, and what you'll see is that these are questions that you can ask the patients that you suspect of abusing alcohol. So C stands for cut down. So you can say, have you ever tried to cut down on alcohol intake and not succeeded? A stands for annoyed. Have you ever been annoyed about criticisms of your drinking? All right. Really quick, these are very common things that we have seen in alcoholics. Most people will simply say, look, I'm not an alcoholic, I have a problem, but I can cut down on it, all right? And these individuals tend to not be successful. Why? Because remember, they're addicted. They've got that addiction pathway going on, resulting in those physical and psychological symptoms of addiction. So when they try to take away the alcohol, they get the delirium tremors, they get the nervousness, they get the fear of others, and so on and so forth. And so they go back to the alcohol, all right? So the A, once again, have you ever been annoyed about your criticism of drinking? A lot of times employers, family members, spouses, children, friends have said to the individual, look, you've got a problem. You need to stop the alcohol. All right. They see the problem a lot of times before the alcoholic sees it. They think they're trying to help out, and what happens is that the person becomes annoyed. No, I am in charge of my alcohol. I can stop anytime I want to. All right, G, guilty. Have you ever felt guilty about your drinking behavior? Just because they're abusing their spouse, or just because they're abusing their children because of the alcohol, or just because Monday mornings are consistently late for work because they're sleeping off a hangover, doesn't mean they don't feel guilty about it. Most of these people recognize that their behavior to an extent is negative, all right, and they feel some guilt about it. They simply can't do anything about it, All right. And then E stands for eye opener. Okay. Have you ever had to take a drink as an eye opener in the morning to relieve anxiety or shakiness? Think about these individuals. They go to sleep at night. They've had enough alcohol to get them through the previous day, and then they metabolize the alcohol overnight. They wake up, the alcohol's out of their system, and so what happens? They get all of the negative psychosocial, psychological, and the negative physical symptomologies of withdrawal because they haven't had alcohol for 8 to 10 hours or even more. Okay. So what do they do? All right, they're shaky, they're nervous, they've got all that anxiety that's going on that are common in withdrawal symptoms, because essentially that's what happened is they've been withdrawing from the alcohol overnight. And so what do? They need an eye opener. They need a drink first thing in the morning to give the body the alcohol that the body is craving so that it'll take away the physical and the psychological symptoms of withdrawal. So there we have it there. Okay, CAGE. Okay, I say there it's important the physician screen for patients for alcohol abuse, but as I mentioned throughout the lecture, it's important that you as a dentist do the same thing because you may be the only healthcare provider that individual sees that year. So what do you do with these individuals if they come back with a positive CAGE screening? Well, you're not expected to treat them, but it would be a good idea if you knew resources were available in your community to give these people the care that they need. All right, maybe they can go and see their general practitioner. Maybe you can recommend a counseling center. Maybe you can recommend they speak with their pastor, or the priest, whoever it happens to be. What are the medical complications? Why do we worry about all this wonderful stuff that we're talking about today? Why isn't it okay that we just go out and drink all the alcohol that we want? Okay, so the reason is there are severe medical complications that are associated with this. What are some of them here? Well, we have cirrhosis. What do you see off to the right there that just looks awful? That is a liver. Right? That's a lobe of the liver there. Okay, the liver is the organ that takes the alcohol and breaks it down into its constituent parts to basically flush it out of the body. Okay, the liver, as you probably already know, is like a giant sieve, a giant sponge. If I take a fresh piece of liver, and maybe you've done this, maybe you eat liver, I don't know, but if you take a fresh piece of liver, whether it's human or cow, whatever it happens to be, you should be able to basically move it around. It's porous. It's spongy feeling, and it's not very difficult to stick your finger right through it, okay? The reason is because that's how it needs to be, because the alcohol needs to be able to filter through the basic constituent components of the liver so it can take out the alcohol and break it down. Here on the right, we see what we call a cirrhotic or scarred liver, okay? When we try to pass too much alcohol through the liver too often for too long, it develops these nodules that you see there, and it basically develops scarring because it's working too hard. Okay, the cirrhotic or the scarred liver, it isn't pliable anymore. Okay, it doesn't feel spongy anymore. The alcohol can't pass through it. So what happens is we have end-stage liver failure a lot of times in our alcoholics who've been drinking too long. Basically, no longer can the liver break down the alcohol, no longer can the liver break down the other substances that it commonly breaks down in the body. And so the individual basically either is going to have a liver transplant or the liver is going to be removed and the individual can't survive with the liver. Okay, so that's one of the long-term complications here. Probably the most common cause of death among our alcoholics is end-stage liver failure resulting from a cirrhotic liver. Okay, alcoholic hepatitis. We don't necessarily need to get into that, but it's a very common cause. Hepatitis is where the liver is not functioning, and so we get back bilirubin in blood, and that's when you get these individuals that have yellow skin and they have yellow eyes. That's a common sign of hepatitis there. Pancreatitis, don't worry about that. Gastric and duodenal ulcers. All right, so these are ulcers within the stomach here. The stomach is not. It's not good at having large amounts of alcohol present in it, okay? And so if you consistently expose the stomach to large amounts of alcohol, basically what the alcohol starts to do is break down the lining of the stomach, and we get ulcers, all right? We get little basically holes in the lining of the stomach, and so the stomach acid and the alcohol continues to make those holes a little bit bigger, and it's very, very painful for the individuals. Okay, this can be a cause of death among alcoholics as well, because basically the alcoholic will bleed to death because of the duodenal ulcers, the gastric ulcers, and so a lot of times in the later stages of alcohol abuse, these individuals will start to spit out blood. Okay, middle-age onset of diabetes. Why? Because the alcohol is high alcohol is high in carbohydrates. Okay, carbohydrates then are broken down into sugars. So in other words, alcohol is a great way to get fat. Okay, there's a reason that we say that the alcoholics have beer bellies. Okay, and a lot of times what we'll see is that the alcoholic is getting the majority of their daily caloric intake from the alcohol. Okay, and because it is a carbohydrate that is broken down into its constituent sugars, then we get the onset of type 2 diabetes in these individuals. GI, gastrointestinal cancer, basically for the same reason we get the duodenal ulcers. We get changes in the histology of the lining of the stomach from constant exposure to the alcohol. Hypertension, so high blood pressure. The hypertension in turn causes stroke or cerebrovascular accidents, another common cause of death among alcoholics. For the men in the audience, large consumption of alcohol may make you feel more amorous, may make you feel like you have a lot more confidence going and talk to those attractive women at the bar or the attractive women at the party. But the problem is you get them back to your place, and alcoholism or large consumption of alcohol, even if you're not an alcoholic, just large consumptions of alcohol and being drunk during the evening when you try to get a little bit more physical with the lady of your choosing, results in erectile dysfunction, all right, which is probably a bit of an embarrassment for the individual who feels all pumped up on the alcohol and they think they're super stud and then have a problem when they get the lady back to their bedroom. Vitamin deficiency, for the same reason that we get a middle-age onset of diabetes. If you're getting all of your vitamin, or if you're getting all your caloric intake from the alcohol, it's not exactly a well-rounded source of calories. It doesn't include a lot of vitamins. You'll get vitamin deficiency. Same reason you get malnutrition and so forth. So you can see the medical complications are significant here for the individual who is abusing alcohol. And these are the reasons that we want to screen these individuals and catch them early on and get them the assistance that they need. Don't worry about this. I'll just mention a few things here. These are the laboratory values and the effect that you get on alcohol. The only thing I want to point out is if you look down 1, 2, 3, 4, 5, you see the triglycerides. Okay, triglycerides are a measure of the amount of fat that we see in the system. All right, so an individual who is overweight, getting most of their caloric intake from poor sources of food, whether that's fatty food or whether that's alcohol in the case that we're talking about, are going to see not only their triglyceride levels go up, but they're also going to see their cholesterol levels go up as well. Calcium, not surprisingly, see their levels of calcium go down. If you look down here, we see that both their white blood cell count, their platelet count, and their hematocrit are also going to decrease. So those are all measures of the different types of cells that we see being produced by the bone marrow of the individual. And the individual who's an alcoholic is going to have decreased production of these things. Consequently, they're going to be at increased risk for common diseases, especially with decreased white blood cell count. They're not going to be able to fight off the common infections, the viruses, and the bacteria that you and I see every day. And so when you take an alcoholic, and particularly one who's living on the street, okay, not only are they going to have the medical complications that we talked about, but they're just going to be overall sicker. They're not going to have the ability to fight off infections as well as a healthy individual with a healthy immune system. Let's start out by talking about psychosocial treatment options, and then in part C, or the final part of the lecture here for substance abuse, we'll talk about medical or pharmacological options that we have. So psychosocial treatment, okay. So the most successful way to get a patient to accept treatment is an employer referral. What do I mean by that? Well, this is a threat. The best way to get somebody to enter treatment is to have their employer come to them and say, you're an alcoholic. If you don't accept treatment and go and get the treatment that you need, you're out of work, okay? Because everybody fears something like that. They fear, oh my gosh, I lose my job, I can't afford the house, I can't afford the mortgage, I can't take care of my wife, the kids, whatever it happens to be, okay? So if the employer says, go and get help, then the individual can still get help. That's why when we mentioned earlier talking about substance abuse and problems among professionals, dentists, doctors, I said, tell them to stop seeing patients and get help. And if they refuse, tell the hospital, tell the clinic, because the hospital and the clinic are going to say, look, stop treating patients and get help or you're out of work. And we know that that's a very successful way for these individuals to go and get help, okay? We all have what is known as Alcoholics Anonymous, or AA. Okay, Alcoholics Anonymous is a non-medical form of treatment. It's basically a buddy system. Okay, and it's very, very successful. Okay, why is it successful? Well, one thing is it's cheap. Okay, it doesn't require professional counselors. It doesn't require a psychiatrist charging $150 an hour. It doesn't require an inpatient detoxification unit. Basically, it requires an individual who themselves is a recovering alcoholic and receives some treatment in counseling techniques that is willing to host events using the program produced by Alcoholics Anonymous. And so what you get is you get a group of individuals that get together 1, 2, 3 times a week, all right, and they are alcoholics, and they're not ashamed to be alcoholics, and they admit to each other, I am an alcoholic. In fact, that's one of the things that they do, is at the beginning of the meetings, everybody goes around the room and they introduce themselves. And so you get up and say, I'm Chone Law, and I'm an alcoholic, all right? And everybody says, hi, Chone, all right? And it's this open, tacit environment where everybody acknowledges that we are alcoholics, okay? So what happens in there is basically they have 12 steps that they work through in terms of admitting that they're an alcoholic and seeking assistance. But the biggest thing that comes out of Alcoholics Anonymous is you get a buddy. You get a senior member of the group who's already been through the program. The idea is that you tend to go back to Alcoholics Anonymous long term, because there really is no such thing as someone who is no longer an alcoholic. All right, once you're an alcoholic, you tend to retain that risk throughout your life. And so what you have is you have recovering alcoholics. So people tend to go to alcoholics long-term as recovering. And so the senior members of the group will be buddied up with a new member. Okay? And the idea is that your buddy provides you mentorship and support. It's a person that you can look at and you can go, hey, if John can make it, I can make it. And the other thing that your buddy does for you is that, let's say you go out to a bar, all right, with your friends, which obviously we don't want the recovering alcoholic to do, but nonetheless sometimes they do these things, okay? And you pick up that first glass of beer, and you're just about to drink it, and you go, no. You think about your family at home, you think about all of the things that you're trying to overcome, and what do? You put the alcohol down, you pick up your cell phone, you can call your buddy, and you can say, hey, I'm down at Clancy's bar, but I'm tempted to drink alcohol, and your buddy is either going to talk you through on the phone, or he might even come right down there to the bar with you and get you out of that situation. All right. So it's effective because it provides a buddy system, and it's effective because it's cheap. Okay. Now, I don't know if Alcoholics Anonymous is available in Fiji, but it's a cheap program. It's an international program, and it would probably be something that would be fairly easy to start up. So if any of you are interested in really making an impact and trying to do something good for the community, that might be something you can look at as a service project among yourselves, among partnering up with the medical students and the nursing students, whatever it happens to be. Okay, why does this work? Okay, basically we're substituting one-time dependence for another. We're substituting dependence on the alcohol, dependence on the group. And I mentioned there that we're also substituting dependence upon a spiritual being. One of the 12 steps is that you acknowledge that you're powerless against the alcohol. And then you have to acknowledge that there is some type of power in the universe that's greater than you. Okay, for people who are Christians, that might be God. For people who are Buddhists, that might just be the sense of the universe, that the universe is greater than you. Okay, but the point is, you acknowledge that there's something greater than you in the universe, that you're powerless against the alcohol, and that you're going to turn your powerlessness over to this greater spiritual being, and that this greater spiritual being, and in turn, working through you, working through your friends in the group, your family that is also supporting you, that you can make the changes that you need to get your life back on track. Okay? The other thing that dependence of the group leads to is they reinforce that drinking is a negative thing, because one of the things that they'll do during the Alcoholics Anonymous meetings is that they'll talk to the group members about what are the bad things that came about in your life because of the alcohol. Did you lose your job? Did you lose your home? Did you lose a family member? Okay, and so on and so forth. So it's a very effective program. The idea is the individual has to keep going back to it. There are also special programs that provide support groups for family and friends of alcoholics, because one of the things you've heard me mention is that the impact of the alcohol is most significant and most severe, not only on the individual who's the alcoholic, but upon their family and friends. Okay, and so there are special groups where family and friends can get together and talk about the impact that their loved one's alcoholism has had on them as well. It's a positive thing. Okay. All topic here in terms of psychosocial treatment that I want you to understand about. We have what we call stages of behavioral change. And this is a psychosocial treatment method that we can use with both alcohol and substance abuse patients, and it's based on what we call the health belief model. The health belief model was developed by psychologists in the United States in the 1970s to help explain why people would engage in health screening programs. In particular, they wanted to know why African American women in the South wouldn't get screened for breast cancer. Okay, it's gone to be expanded and helps us not only understand why people don't want to change, but also the stages that they need to progress through in order for them to change. All right. So, what are the different stages here? Okay, of the health belief model. Well, we have what we call the pre-contemplation phase. This is the phase in which the patient is unaware of the problem and seeks to continue the behavior for various psychological as well as physical reasons. So in other words, this is the individual saying, I'm not an alcoholic. I'm a social drinker. I drink on Friday nights with my buddies and on special occasions and things like that. I'm not an alcoholic. I don't want to change. Okay. Eventually, though, the problem, they start to recognize the problem. All right, they start to see the impact of it. Family and friends, bosses begin to point it out to them. So they move into what we call the contemplation phase. So they become aware of the problem, but they don't want to change. Right? So what? I've got a drinking problem. All right, plenty of people I know have got drinking problems, and they still function just fine. All right, so we move from pre-contemplation to contemplation. Okay. Then eventually they're going to move into what we call the preparation phase. Okay, they become aware of the damage to themselves. They start to see a problem. Maybe this comes about because they come home from work one day and there's a note from the wife, and she's packed herself and the kids up and taken it to her mother's house, and the note says, you need to get help. You're an alcoholic at this point. Or maybe this is the phase where the boss says to them, look, you're an alcoholic. If you don't change, I'm going to fire you. The point is, they start to think about the damage that they're doing to themselves, okay? And what do? They're going to start to make some type of an effort to change. Now, going back to this idea of the health belief model, one of the tenets of that is the patient has to believe they can change. Okay, that's a psychological barrier for the patient. Think of that as a mountain or as a door that the patient has to either climb over or walk through. And if they don't believe they can change, all right, if they don't believe they can walk through that door, climb over that mountain, they're simply going to sit there and wallow in their own self-pity and allow the alcohol to destroy their lives. All right, so it's very critical that the individual gets the type of help that allows them to believe that they can change and that they can make the necessary steps to better their own life. All right. So in theory, if they can overcome that barrier, then they move into the action phase in which the patient engages in more active steps to change their behavior. Now, a lot of times this is trial and error at this point, okay? Because a lot of times they realize there's damage in their life, but they're not quite willing to go to their doctor yet, all right? So what do? They'll go on the internet. They'll search online to see what works for other people. They'll talk to friends and they'll talk to family that they trust. Maybe they'll go and they'll talk to their preacher or their religious leader, whoever it happens to be. Okay, and they want to take action and they're attempting to take action, but it's just not quite there yet. Okay, now. Eventually what they're going to have to do is they're going to have to work into what we call the maintenance phase, okay? They're going to have to seek professional help. Now, are there individuals that can simply quit drinking and consuming alcohol to the point that it hurts them without seeing a doctor or psychologist? Yeah, but there are very few of them. Most people are going to have to seek some type of professional care, okay? Most oftentimes it's going to be their family doctor, their internist or general practitioner who, while not ideally suited for treating real serious cases of alcoholism, can do some of the work. Okay, we'll also probably refer them to a therapist, also refer them to Alcoholics Anonymous. You can be that individual as well. All right, you as a dentist can use the cage screening model, and you can be the individual that can refer them to the individual that get them more help, whether that's a doctor or a therapist, whatever it happens to be. Okay, now the maintenance phase, remember the rule of Fort no thumb that we talked about? They're probably going to go into the maintenance phase and they're going to fall out of it. And they'll have to cycle back through before they get back to the maintenance phase again. Usually about 4 times before the individual achieves honest to true abstinence from the alcohol. Okay. One of the big things that we focus focus on in the maintenance phase is this idea of relapse. We help them understand that just because you're not drinking alcohol this week, just because your wife has come back to you, just because the kids are giving you hugs again, the boss wants you back at work, doesn't mean you're at risk. You're not at risk, okay? We really focus on them that they need to continue to go to Alcoholics Anonymous. They need to continue to work with a therapist or psychologist if they are doing that. And if they are getting some type of pharmacological therapy, which we'll talk about in the next section, they need to continue to do that under supervision of their physician as well. Okay. Return to old habits is very common. They get stressed at work. All right, have some type of situation. Like I mentioned, they go to the bar with their friends on a weekend. What do? They smell the alcohol. They see their buddies kicking back the Coors Light, and they smell the cigarette smoke. All of these are triggers, all right, that would help, that would cause the individual to relapse. And so we need to counsel them on that. Don't go to the bars. All right, don't go around the things that will cause you to want the beer. Find other ways to get the positive reinforcement in your life at that point. Otherwise, relapse becomes a problem. Like I said, the cycle may be repeated.